Hello, guys. Good evening. Welcome to the ophthalmology session where we will be doing all the high yield PYQ topics which are important for your upcoming FMG 2025 examination. So, please let me know if my audio and video are good to go. Can you hear me, guys? And for the sake of convenience, I have taken these topics topic wise. So we will be doing topic wise ophthalmology and just the crisp and concise ophthalmology dealing with the ultra important PYQ topics. Hi Harsh. Good evening, Pranjali. Hello everyone. Welcome to the session. Um, I hope you people are doing good. And as the new year is coming, is also coming with your good luck. So if you are consistent in your hard work, there is no need to panic. There is no need to be anxious. I know, exam always bring anxiety, but if you believe in yourself and you know that you are working hard and consistency is there, then definitely this hard work will pay you off. Hi, hello Dinesh, Adil, Mohammed, Faisal, Dr. Official, Amit, Yashwant. Hello everyone, welcome. So you can see that I have divided this uh, PYT session into the different topics. Like first, we'll be taking the topic of lens and all the PYTs related to the lens we are going to do. So along with the PYTs, I'll also remind you of the PYQ that has been there along with your examination, right? I'm good, Utkarsh. How are you? So the first important thing is the onion peel appearance. Can you tell me, guys, where do you get this onion peel appearance? This is actually a slit lamp picture. So whenever we have this kind of slit lamp picture, always remember that the convexity is the cornea, and you are going to get the biconvex lens, something like this. Okay, so the surface towards the good evening shabby the boxer dog. So this is the anterior surface, and this is the posterior surface, and therefore the opacity which is present at the posterior side, this will be your posterior polar cataract. You people are very correct. This is the posterior polar cataract, and posterior polar cataract gives you the typical appearance which is called as the onion peel appearance. So first of all, it's a slit lamp finding. How to find out? With the cornea, the lens, anterior surface, posterior surface, and the opacity is lying at the posterior pole. Therefore this is the posterior polar cataract, and posterior polar cataract shows you the typical appearance called as the onion peel appearance, right? Hello, Abhianand. How are you? So next important thing, second very important thing is the KF ring. So what are the things that you know about the KF ring, guys? This is the Kaiser Fleischer. Kaiser Fleischer ring, which is actually a ring which is due to the copper deposition. So this ring is due to the copper deposition. You can see this one, and it is golden brown in color. That is also important. It is reversible, and it is found in the Wilson's disease. These are the important things that you should know about the KF ring. KF ring is having the copper deposition. Copper deposition is reversible on treatment here, and it is golden brown in color. It is found in the Wilson's disease, and it is present in the Descemet's membrane. Presence in the Descemet membrane of the cornea. So deposition of the copper is taking place in the Descemet's membrane of the cornea. And another important thing, it is associated with the low levels of the ceruloplasmin. It is associated with the low levels of the ceruloplasmin. So all the questions related to the Wilson's disease along with the KF ring, and what kind of cataract is found here. The type of cataract which is found here is the sunflower cataract. The type of cataract which is found here is the sunflower cataract. So two important things we have done. One is the onion peel appearance, one is the KF ring along with the Wilson's disease, and all the questions related to. So we are doing the 360-degree perspective. If you already know that this topic is important, you can get any question related to it. So what we are doing, 360-degree perspective. All the other questions which are important also we are doing. So right, therefore, there are maximum chances that most of the questions will come from this session, right? Now coming to another important thing. What is this, guys? Can you comment? What is this? What is this finding? This is again a slit lamp picture you can see, and what you can see, can you comment here? First of all, you should know that it's a slit lamp finding. Number two, you should know what is there, and then we will discuss that what is the source of this finding. So very correct. This is actually the blood in the anterior chamber. This is the blood in anterior chamber. Now, what is this called as? If you are having blood in the anterior chamber, this is called as the hyphema. This is the hyphema, that is blood in anterior chamber. One is called as hypopion, one is called as hyphema. Hypopion is pus in anterior chamber, while hyphema is blood in anterior chamber. Exactly, Nancy, very correct. This is hyphema. Now, what is the most common source of this hyphema? Most common source of hyphema is the major arterial circle. Most common source is the major arterial circle. Now, where is this major arterial circle present? Major arterial circle is present at the root of the iris. It is present at the root of the iris or the base of the iris, right? Then coming to the topic of glaucoma. So, important things about the lens we have done. Now we are coming towards the glaucoma. Let's see what are the important things in the glaucoma. You can never forget your bablu here. So, this is actually the bablu, where we are having the blue baby boy Bablu. Blue is the sclera here. Baby less than 3 years of age. Boys bilateral is there. And then we will have the BPL card. This Bablu will be coming with the BPL card. You can see the bilateral involvement. You can see the blue sclera. Then we have BPL card where we have the blepharospasm. So this is again very, very important, and time and again we have got the questions related to photophobia, lacrimation, lid spasm. Like blepharospasm is the lid spasm. P for photophobia, we are having the photophobia, and then L for the lacrimation. We are also having the lacrimation here, right? And along with this, now this bablu, if you want to make sure, first of all, we are having this blue baby boy bablu, right? Blood screen. How the screen is blurred, check for yourself. I think it's clear from here. Then along with this, we also have a hazy cornea. Hazy cornea is there. Then we also have the megalocornea. Hazy cornea, megalocornea. So even if you have these many things, it is more than enough. Blue baby boy bablu, bilateral, with the BPL card, with the hazy cornea, along with the megalocornea. बबलू अगर आता है, I think mostly chances हैं, because it came in NEET PG 2023, and I'm sure that many of the topics from this will be repeated in your January paper, and it's very a topic which is very, very favorite of the examiners, which is coming even in NEET PG, and a question that has already come in NEET PG can definitely be coming in your examination, right? Now see this. This is again very, very important. This picture is again very, very important, and this kind of picture was there in NEET PG 2024. This is actually the acute red eye. Acute red eye. Now, whenever I say that it's acute red eye, either it is the acute congestive glaucoma or it is acute anterior uveitis. So what you have to see, whether it's a dilated pupil, look for the pupil. We will have the dilated pupil or you have the miotic pupil. So I am telling you the straightforward things that you have to see as if you are giving the examination. If you see this kind of picture where you are seeing the acute red eye, then look at the pupil. So here you can see it's a dilated pupil. Because it's a dilated pupil, therefore your answer will be the acute congestive glaucoma. If it is irregularly dilated, then again you will have acute anterior uveitis. Here you can get irregularly dilated pupil. Irregularly dilated pupil. Why? Because of the synecdoche. Because of the synecdoche, here you can get irregularly dilated pupil. But if you are getting fairly, total dilatation of pupil, then it is acute congestive glaucoma. Now, apart from this, what are the other things that we can have in acute congestive glaucoma? Obviously, you have so many things by which you can confirm. Like we will have very high intraocular pressure. And when the IOP is very high, nausea and vomiting will be there. Stony hard eye. This will be written in your question. Stony hard eye. And they will also give you the colored halos. So these things are again making your diagnosis very, very easy. A female, right, more than 50 years of age, coming with all these features is definitely having the acute congestive glaucoma. And along with this, they can also tell you about the Vox triad. Vox triad is also found in the acute congestive glaucoma, right? Yes. Harps tria, Utkarsh, yes, the Harps tria, H for harp and H for horizontal, are found in Bablu. Right, guys? So now this is again your FMGE PYQ, very, very important. You can see a opening in the iris. So if opening is a round one, then it is the laser iridotomy. Then it is a laser opening. Laser iridotomy. Which laser will be used, guys? Which laser will be used? Anybody who can comment which laser will be used to make the opening? It is again most commonly used laser. Yes, Nd:YAG laser. Most commonly used laser is the Nd:YAG laser 1064 nanometer. This is most commonly used laser, and the mechanism here is photo disruption. Mechanism here is the photo disruption. We have different kinds of lasers having different mechanisms. Photo disruption is there, photocoagulation is there, photoablation is also there, and here we are using the photo disruption and the egg laser. Yes. While if you are getting a triangular opening, then it is PI. That is the peripheral iridectomy. Then it is the peripheral iridectomy that we are using. This is the surgical opening. So we can use both for the acute congestive glaucoma. I have shown you the picture. I have given you the DD, the clinical features, as well as the two treatments that we can do. Either we can do laser iridotomy or we can do the surgical PI. Any one we can do. Yes. Now see, another important thing is this. Here you can see the pigments on the posterior surface of the cornea. These pigments are called as the Krukenberg spindles, and they are found in the pigmentary glaucoma. And they are found in the pigmentary glaucoma. Now pigmentary glaucoma is a secondary open angle type of glaucoma. Pigments are causing trabecular blockade. And always remember your cheat code that whenever we have trabecular block is always equal to open angle type of glaucoma. Whenever we have trabecular blockade, it's always open angle type of glaucoma. Yes. Right. Now, a very, very important topic, the retina. And most of the times we are getting more than one question from retina. It is equivalent to two topics. As I always say in the class also, you will get about 2 to 3 questions definitely from retina. So look at it very, very carefully. First of all, these are all the layers of the retina. So we have 10 layers, right? We have 10 layers of the retina, and we are starting with the retinal pigment epithelium. So this one is most resistant. This is most resistant to the radiations. When I am talking for the radiations, then this layer is most resistant. Then which layer is most sensitive? The layer which contains photoreceptors. Therefore, the layer of rods and cones is most sensitive. So, layer most resistant to radiations and layer which is most sensitive to the radiations we have. And also remember that rods and cones are first order neurons. Another important thing is that these are the first order neurons. Okay, again, so many students message me about the bipolar cells and the rods and cones. So now you do not have any confusion, guys. Rods and cones are the first order neurons and bipolar cells are now the second order neurons. There is no more controversy we have. And we have total of 10 layers. Apart from this retinal pigment epithelium, the remaining of the 9 layers, this forms the neurosensory retina. This is forming the neurosensory retina. So neurosensory retina will consist of 9 layers, and one layer is your RPE layer. Total 10 layers ho gaya. Outermost layer, then layer of photoreceptors, most resistant to radiation, most sensitive to radiations. And along with this, what are the second order, third order, as well as fourth order? Uh, which layer has retinal detachment? Okay, so I'll be talking about the retinal detachment also. Just wait. First order, I have told you about the rods and cones. Second order is the bipolar cells. Bipolar cells ho gaya second order. Third order is your ganglionic cells. These are the ganglionic cells, and then fourth order is the lateral geniculate body. First important thing. Now, whenever there is a retinal separation, if I am talking about the retinal detachment, actually it is a retinal separation. So, whenever there is a retinal separation between the RPE layer and the neurosensory retina, on one side we have RPE layer, another side pe we have 9 layers of neurosensory retina. Now whenever they are getting separated, then that is actually called as retinal detachment. So detachment is a misnomer. Actually it is not a detachment, it is just a separation. Okay, Harsh, have you got your answer now? Now the most important DD of the ophthalmology, the cherry red spot. Now, one more thing I wanted to tell you before, yes, Nancy has started writing scenario, but a cherry red spot can be found at so many places. So, looking at cherry red spot, you cannot say it is scenario. You have so many things. Yes, if we have a pale retina, right? We have pale retina, we have a RAPD present, right? Then I can say that this is CRO. So you have to always look at the other clinical features, only then I will comment on its cause. If I talk about the DD, then it is actually the cherry trees never grows. Cherry trees never grows tall in the mud and the sand. Cherry trees never grow tall in mud and sand. So it can be due to CRO, then it is Tay Sachs disease. Then we have the Niemann Pick disease. Then gangliosidosis is there. Gangliosidosis. Then T for trauma. Trauma also can give you the cherry red spot, especially we are talking about blunt trauma, which will lead to the Berlin's edema. This will lead to Berlin's edema, which is occurring in the macula. And then this is the metachromatic. Cystoid macular edema will not give you the cherry red spot. This is the macular edema, which is called as the Berlin's edema. Don't call it as cystoid macular edema. Cystoid macular edema means cyst-like spaces. Metachromatic leukodystrophy. leukodystrophy is there, and then we have the send-off disease. Send-off disease, right? So please remember all the causes of cherry red spot. If cherry red spot is having the RAPD also, then definitely it is due to the CRO. Right now, see, very, very important. Can you recognize this? This is your beautiful splashed tomato appearance. Beautiful splash tomato appearance hai. And you can see these ones. These are your soft exudates. Soft exudates or the cotton wool spots. Or the cotton wool spots which are found in cases of the CRVO. Plus, you should know that it is actually the ischemic kind of CRVO where you are getting the splash tomato appearance. Ischemic kind of CRVO. So, the picture of CRO and CRVO are very, very different. One has cherry red spot, one has a tomato splash appearance. Both will be coming with a sudden and painless diminution of vision. So they will definitely give you the fundus finding in the form of picture, in the form of theory, and you can recognize. Right, guys? Yes, so many tomatoes there. Right? Now see this beautiful hypertension retinopathy. Hypertension retinopathy will give you the nasal angiospasm. Nasal angiospasm is actually the first sign that you are getting in cases of hypertension retinopathy. We are getting the arteriolar thinning, artery thinning, right? So recently there was a question also in INSET, what is a normal AV ratio? So when I talk about normal A is to V ratio, it is 2 is to 3. Even you people should know this when I am comparing the lumen, the diameter, thickness, caliber है ना of the artery and a vein. तो va for va veins are always wider. ठीक है, veins wider है, artery thin hai. Now again here we are having more thinning. Spasm means thinning. So here it is becoming 1 is to 3. From 2 is to 3 it is becoming 1 is to 3. Right? So this is the first sign. Uske alawa you can see these hemorrhages. These are the flame shaped hemorrhages. And you can see these large exudates, cotton wool spots. Cotton wool spots hai. So if we are having the angiospasm, we are having the flame shaped hemorrhages, we are having soft exudates or the cotton wool spots, you are sure it's a case of hypertension retinopathy. Flame shaped hemorrhages are superficial hemorrhages. So this is total hypertension retinopathy. They will give you some evidence of hypertension, or they can give you the picture, they can tell you about flame shaped hemorrhages, soft exudates, they can tell you about the arteriolar thinning, they can tell you about the AV ratio, and definitely they can ask you a question. No treatment. We do have no specific treatment. So though we have some treatment available for the diabetic retinopathy, hypertension retinopathy ke liye we do not have any of the specific treatment, because you cannot bring back the arteries back. Whatever has thinned out, whatever has gone into spasm cannot be reverted. You can only prevent the progression. Okay, so there is no specific treatment. Right. Now, again, a very, very important picture. This kind of picture was there in even NEET PG 2024. And you cannot have a paper without a question on diabetic retinopathy. You people know. And I have told you this many times in the classes, live app, in recorded sessions, live sessions everywhere, that you cannot have a paper without diabetic retinopathy. So look at this very, very carefully. No NP, it's a non-proliferative state. So that means no neovascularization. First of all, the most important thing, NPDR, PDR, non-proliferative, proliferative. So you should have no evidence of neovascularization. Now what you should have? The first thing is you will have small, small hemorrhages, which are the microaneurysms. This is the hallmark. Microaneurysms is the hallmark. Then we have dots also. Then we have blots also. And you can look at the exudates. There are hard exudates. So the hard exudates are again very, very smaller. These are smaller than the soft exudates, and these are the deeper hemorrhages. You people are very, very correct. Like there we were getting the superficial hemorrhages. Here we have deep hemorrhages, soft exudates, hard exudates. Microaneurysm is the hallmark, and plus no neovascularization. No neovascularization is there. Then you are sure that it is a case of NPDR, right? Yes, ETDRS chart is there. ETDRS chart is there. And another important thing, the investigation of choice is the FFA, another important thing. And then we have the most important risk factor. When I am talking about the most important risk factor for the diabetic retinopathy, then it is the duration. It is the duration of the diabetes which is more than 10 years. If the patient has lived with the diabetes more than 10 years, then definitely he has more chances, more risk, more potential of going into the diabetic retinopathy. Stages may you have seen, number one was NPDR, number two is the PDR. PDR is proliferation, proliferation is equal to neovascularization. So one will have no neovascularization, one will have neovascularization, and this neovascularization is actually the hallmark of the PDR. It is the hallmark finding. So whenever we have the PDR, you always know that you will get the neovascularization. While the hallmark of NPDR is the microaneurysms, the hallmark of PDR is the neovascularization. And this neovascularization can be NVD, like it is at the optic disc, or it can be NVE also. NVE means elsewhere, and NVD means at the optic disc. Then number three, you can have the diabetic maculopathy. Diabetes may you can get the cystoid macular edema, and fourth may advanced stage may you can have the complications. So these are the four stages of the diabetic retinopathy. Cystoid macular edema can be there, and advanced may complications may neovascular glaucoma, TRD. In fact, recently there was a question on TRD also. TRD may they had asked that which of the following can be associated with TRD, and answer was diabetic retinopathy. This was also asked in 2024. So this is again important. Diabetic maculopathy, this will be the most common cause of the diminution of vision. Most common cause of the diminution of vision in the patients of diabetic retinopathy will be the maculopathy or the macular edema. Right now, this is again a very important picture of 2024. There are two questions that have been asked in 2024 regarding the retinitis pigmentosa. You can look at the typical triad here, and here we have like number one this, then we have this is the number two, and then we have the number three. Now what is the triad here? Number one may we are getting the pale yellow and waxy. Pale yellow waxy optic disc is there. Then number two is the pigmentary spicules. So you can see there are so many pigmentary spicules because it is affecting the RPE layer of the retina. So we have so many spicules in whole of the periphery. And number three is the arteriolar arteriolar attenuation, right? So this is the typical triad. The picture is again very, very important, and you can see that here what is happening, it is affecting the periphery, pigmentary spicules. So these are occurring in the periphery, and periphery may means rods are affected, and therefore the first symptom that you are getting in the patient is the night blindness. So this is the earliest symptom that we are getting. So one of the question was on the night blindness, another question was on the picture. Both I have told you, the triad of retinitis pigmentosa. Investigation of choice is the ERG. Utkarsh, there were two questions on retinitis pigmentosa this year. One question in INSET May 2024, and another question the NEET PG 2024. So I am keeping my finger crossed that this is coming in your FMG examination too. Please read the retinitis pigmentosa very, very carefully. Investigation of choice is the ERG, and inheritance pattern may it can be spontaneous, sporadic pattern hai, and followed by rather sporadic. So the most common is the sporadic pattern, and followed by the familial like autosomal recessive, autosomal dominant, and X-linked recessive. Yes. Definitely, I am very very hopeful that so many questions will be coming from this PDF. Now, very very important FFA pictures. Some of the typical FFA findings that you can get. One is this is the CSR. CSR में beautiful picture you can see. It is the pattern mushroom pattern that you are getting in the FFA, and you are sure when you see this picture you know that it is CSR. What history you would like to take from this patient? So always take the history of stress from this patient, history of smoking, history of stress, history of smoking, as well as history of stress. These three are very, very important, and all three are common in the business officials. Therefore, usually they will give you the question on the business officials. This will be written in your question paper. And treatment. Another important thing is the treatment and the another FFA finding. One is the mushroom pattern. The second finding that you are getting is the ink blot pattern. Ink blot pattern, or which is also called as the enlarging dot sign. Enlarging dot sign is there. Treatment may just wait and watch. Wait and watch, and you will get the spontaneous resolution in about 4 to 12 weeks. That is why usually we are doing wait and watch for the CSR. The two patterns of FFA is important. History that you would like to take from the patient, that is also important. Okay. This is another pattern. The second is the ink blot pattern that I was telling you. Two by things. Yes. Two things that you are getting in the CSR. Treatment, I have told you. Then another important thing, the flower petal appearance. Typical flower petal appearance hai. Now why we are getting this flower petal appearance? Due to the petaloid fibers. Because of the petaloid fibers in the outer plexiform layer of the macula. Because we have petal-like fibers, therefore petal-like appearance, and this layer is also called as the Henle's layer. Another PYQ, this layer is also called as the Henle's layer. So one is the macular detachment, that is CSR, and one is the macular edema. Then three different kinds of FFA findings. Treatment is obviously different here. You will give the steroids. CME may we will give the steroids because it is a sign of inflammation, the macular edema. Detachment may we were doing the wait and watch. So their comparison. Now again a master blaster question which is going to come in your exam. The retinoblastoma, a very very typical question, less than 3 years with the leukocoria. Less than 3 years baby is coming with leukocoria with typical cauliflower-like growth. Cauliflower-like growth is there, and the typical with the Flexner Wintersteiner rosette. So this kind of question they are giving, and you can see this, yes, this lumen is there. These are the Flexner Wintersteiner rosettes, and this is very very typical of retinoblastoma. I do not know why they always write, while in text I have never seen cauliflower like growth written for retinoblastoma, but in your PYQs it's always like this. We have a less than 3 years ka baby hai, leukocoria hai, cauliflower like growth hai, and usually they are writing in theory that there are Flexner Wintersteiner rosettes, so you know that it is a retinoblastoma. And always remember that leukocoria any leukocoria in less than 3 years of age, okay, should be considered retinoblastoma unless proved otherwise. Unless proved otherwise, you should always consider it as a case of retinoblastoma. A very very important thing, even if they have not told you what is the reason of leukocoria, but if there is any baby who is less than 3 years of age and you are getting leukocoria, please take it as a case of retinoblastoma. Another kind of rosettes that you can get here is the homerite rosettes. These are actually the pseudo rosettes. These are pseudo rosettes where no lumen is seen. No lumen is seen. These are the pseudo rosettes. So again, you can get both in the retinoblastoma. You can get the true rosettes also, and you can get the pseudo rosettes also. Both can be seen. Very, very important. Acha, one more thing. What should be the investigation of choice? In one of the notes, somebody, other day I was taking the live session and somebody shared the screenshot of another notes that are circulated in the market, that it was written that X-ray and CT scan is the investigation of choice for retinoblastoma. No, guys. Here, babies less than 3 years of age, so we will always avoid the radiation exposure. So MRI is the investigation of choice. There should be no confusion. That is why I'm telling you here also, please don't mark anything wrong. MRI is the investigation of choice, not CT, not the X-ray. Now coming to the cornea. Cornea is a easy one, but again very, very important, and we are always getting questions on the corneal ulcers. Hmm. Right. So first to start is a bacterial keratitis. Bacterial keratitis may most common is always Staph aureus. Staph aureus is the most common cause of the bacterial keratitis, and you will always get a single large ulcer. You will always get a single large ulcer because we have no hyphae. So this is the basic difference between the fungal keratitis and the bacterial keratitis. There you can get satellite lesions because we have the finger-like extensions. We have the hyphae, but here we have no hyphae, and plus you will have the acute red eye. It will also present with the acute red eye, and the hypopion that you are having in cases of the bacterial keratitis. That is always sterile as well as always mobile. Very, very unique of the bacterial keratitis because there's nothing which can penetrate inside. So it is mobile also, it is sterile also. You have acute red eye because of the acute anterior uveitis. You can see lot of redness. So this is the vascularization. Very, very typical vascularization is there. And because we have vascularization, we will also have perforation. So I have written so less words, and each word is important. If you are having any of these words, it is actually the bacterial keratitis. अगर vascularization है, perforation है, hypopion which is sterile, which is mobile, acute red eye है, acute anterior uveitis है, single large ulcer है, all these are the characteristics of the bacterial keratitis. While fungal keratitis is exactly the opposite of it. Here you will get the history of vegetative trauma. First of all, very, very important, you will get the history of vegetative trauma. Vegetative trauma में plant material can be there, or it can be animal tail injury. So any one history you are getting. Apart from this, most common is aspergillus. Most common is aspergillus, followed by the fusarium. This is the name of the fungus. Then another important thing, signs are always more than the symptoms. We do not have much symptoms, but signs are more. Because why there are less symptoms? Because there is no vascularization. Yes, because there is no vascularization as well as the perforation. Because we have no vascularization or perforation, therefore we have no redness. Here you will have dry looking ulcer, grayish ulcer is there with the multiple satellite lesions, with the multiple satellite lesions hai, very, very typical finger like projections are there. Finger like projections are also there, and then we have immune ring of the Wesley, that is a demarcation ring that is there, and a hypopion, not to forget about a hypopion which will be non-sterile as well as non-mobile. Very, very typical. So yes, they are giving you history of a person coming from the rural background है, farmer by occupation है, trauma by leaf, root or wood, stem, animal tail. All these are there, and the treatment of choice is the natamycin. Treatment of choice here is the natamycin. Now, again, look at this picture carefully, and this picture will also come in your exam. This picture has so many times been asked in your paper. Last year, this picture was there in NEET PG 2023 also, and they had not asked the name of this lesion actually, they had asked the name of the stain. So the stain here is the fluorescein stain. It is the fluorescein stain, and the filter that we are using here is the cobalt blue filter. That is important. Secondly, what is the name of these ulcers? Very, very specific dendritic ulcers. Where you are getting dendritic ulcer, guys? Dendritic ulcers hai. Dendritic ulcers are found in the herpes simplex virus. These are the true dendrites where you are getting both the what you called as both the floor as well as the knobs. Something like this. Knobs are also there. So these are called as the knobs, and knobs are present in the true dendrites. Knobs are always present in the true dendrite. So whenever you are having these kind of ulcers, always remember that steroids are contraindicated. Another important PYQ hai, here steroids are contraindicated because they can hasten the formation of larger ulcers. So we can have collision of the knobs and it will form a larger ulcer. They are called as amoeboid ulcer. So looking at this picture, name of this ulcer, where it is found, how they are true dendrites, steroids are contraindicated, and the name of the stain and name of the filter. These are the other important questions related to it. And finally, the fourth type of keratitis, the acanthamoeba keratitis hai, where you should remember the ARCA for acanthamoeba, which is a amoeba, right? And R for the ring abscess. Ring infiltrate or the ring abscess hai, along with the radial keratoneuritis. Along with the radial keratoneuritis, we have the ring-shaped abscess hai with the radial keratoneuritis hai. You can see here we are having this ring-shaped ulcer. And C for the contact lenses. Usually you will get a history of contact lenses. And C for culture also. Culture we are doing on the non-nutrient agar. Culture we are doing on the non-nutrient agar, which is enriched with the E. coli. Non-nutrient agar enriched with the E. coli. Right? Treatment of choice here is the polyhexamethylene by guanine. This is the treatment of choice. So all four infective ulcers, their characteristic features and treatments along with the pictures we have done, very, very important. Hai. Another important thing is the keratoconus, where you can see it is usually bilateral hai, as well as non-inflammatory. As well as non-inflammatory hai, conical ectasia. We have the conical ectasia of the cornea, something like this. And this will lead to the myopia along with the astigmatism. This is the refractive status of the patient. The refractive status of this person is myopia along with the astigmatism, because we have increased axial length here and the surface has become uneven. So this will be the refractive status. Then if you look at the signs of the keratoconus, mein very, very important is the oil droplet sign, oil droplet reflex. Treatment for bacterial keratitis is antibiotics. Treatment for fungal ulcer was antifungal. So there we were having one drop which was favorable, natamycin. That is why I have told you. Antibacterial may you have so many choices of broad spectrum, gram positive, gram negative. That's why I haven't typically told about that. Then oil droplet reflex ho gaya. Fleischer's ring. Another important thing is the Fleischer's ring. This you should know, because KF ring mein there was copper deposition. Here we have iron deposition. Then we get the Vogt stria. Another important thing is the Vogt stria. Vogt stria, V for Vogt and V for vertical, H for half and H for horizontal. Then you are also getting the scissors reflex due to the astigmatism. we are getting the scissors reflex along with the Munson sign. So all these signs you should know, which are associated with the keratoconus. Treatment of choice may we will start with the rigid contact lenses. Yes, so starting with the rigid contact lenses, and we can go even up to the keratoplasty, but we can start with the rigid contact lenses. Rigid contact lenses are the most favored one. Now, some of the important topics of the conjunctiva. Conjunctiva ka one or more pictures are always asked repeatedly, and one of them is this. You cannot have a paper without this. This is your vernal keratoconjunctivitis, which is actually the most common allergic conjunctivitis. And this is typically present in the young males with the type 1 hypersensitivity reaction hai. Exogenous allergy, you will get a history of exogenous allergy along with the diffuse polygonal raised area. So polygonal may, like, it can be pentagonal also, it can be hexagonal also. So whenever you are getting such kind of things, you are sure that it is a case of the vernal keratoconjunctivitis, especially if they are complaining of itching. Itching is very important in allergy along with the ropey discharge. If they are having the itching along with the ropey discharge, then they can also complain of what? Horner Trenta spots. We can also have Horner Trenta spots. We can have shield ulcers. And what is the treatment of choice, guys? Treatment of choice will be the olopatadine. Treatment of choice is the olopatadine. Now, because recently trachoma has been eliminated in 2024, so definitely you can have a question on trachoma, right? It is eliminated in the year 2024, so I'm expecting a question on 2025. And there was a question on trachoma, image-based question in 2024 NEET also. So very typical sago grain follicles हैं. And on the microscopy we can get the necrosis also, as well as the multinucleated cells. The Liebert cells can also be there, very typical of the trachoma, along with the sago grain follicles. You can also get the other things like papillary hyperplasia. We can get the papillary hyperplasia. We can get the Arts line. This is also important. Arts line is important, along with the Herbert follicles and the Herbert pits. Herbert follicles and Herbert pits are there. And then we will also have the Fisto WHO staging. WHO staging, that is your Fisto, that is there. And also remember the SAFE strategy. SAFE strategy is there, where S is for the surgery, A for antibiotics, then F for the facial cleanliness, and then we have E for environmental hygiene. Environmental hygiene, right? So both are important. Recently there was a question on Herbert pits. This was there in the NEET PG 2024, and this is also a PYQ, right? So this is also important. Then next is pterygium. Again, a very important PYQ topic है pterygium. Pterygium में we are having both hyperplastic plus the degenerative changes. Both are there, and type of degeneration will be elastotic type of degeneration. The type of degeneration is elastotic type of degeneration, because here we are having a growth, so we are having both kind. Elastotic type of degeneration, and you can see the growth here. We are having the three parts here. One is this, one is this, then second is the neck portion, and this is the body. This is the elastotic kind of degeneration है. Parts you can see, parts of the pterygium में we have the apex of the pterygium, then we have neck, and then is the body. Then is the body. These are the three parts of the pterygium. And the diminution of vision. Now, why we are having the diminution of vision in the patients of pterygium? Number one, we can have with the rule astigmatism. Another important question, the most common cause for the diminution of vision is the astigmatism. Then we can also have the pupillary obstruction. So it can obstruct the pupil and it can cause the diminution of vision. It can also cause astigmatism. But if they ask you the most common, then it is the astigmatism only. This was asked in 2019. Then you are getting a Stalker's line. Another important thing here is the Stalker's line. Stalker's line mein you are getting the iron deposition. And another important thing is the treatment. Treatment mein surgical excision. Surgical excision we have to do, but here we will have lot of recurrence. So how much recurrence we can have? It is up to 80% recurrence is there, and we can reduce this recurrence by the mitomycin C. So you can cover it with the mitomycin C, or we can give the thiotepa. We can do the conjunctival autografting. We can do conjunctival autografting, then beta radiations. We can emit the beta radiations there, and finally we can do the amniotic membrane grafting. All these are the methods of reducing the recurrence. So there are so many questions. Once there was a paper where three questions were there in a single set. There were three questions from pterygium. So again, pterygium is an important topic. White spots. White spots, you can see these are the white foamy spots. White foamy spots hai, more common on the temporal side. While whenever we are talking about pingicula, we are talking about pterygium, they are always more common on the nasal side. These are more common on temporal side hai. Found in the vitamin A deficiency. These are found in the vitamin A deficiency due to the hyperkeratosis. Due to the hyperkeratosis of the epithelium. So normally when we have the epithelium, there is non-keratinized epithelium. When it becomes keratinized, the change of epithelium from non-keratinized to keratinized. This will lead to the white dot spots. Right? You are having any of the doubts? You can keep on commenting there. Next, we are coming on the eyelids. Now, looking at some of the deformities of the eyelids, you can see here we are having the rubbing of eyelashes. This is called as the trichiasis, where we are having the rubbing of the eyelashes over the cornea. When we have the rubbing of eyelashes over the cornea, then this is called as trichiasis. While if you see this one, here, die means two. So here we have two rows of the lashes. When we have two rows of the lashes, then it is dystichiasis. When there's a rubbing of eyelashes, then that is called as trichiasis. And when we have no eyelashes or the loss of eyelashes, then this is called as madarosis. Madarosis is important because this is found in leprosy or the Hansen's disease. So you can get a question with respect to the leprosy also. No eyelashes is called as the madarosis. Now, the all-time favorite for the FMG examination is the lacrimal apparatus. So guys, here though I have written whole of the test, but basically I want you to know that what the name of the test, and this test is actually used for what purpose. So this is for your the epiphora. So you should know that this test is done for the epiphora when I want to find out the cause of the epiphora when we have hyperlacrimation. That time we are doing this Jones 1 test and the Jones dye test 2. Okay, you don't have to go into the detail, just know the names of these tests. Jones dye test 1 है, Jones dye test 2 है. So whenever we are doing actually the test 1, here we can have the hyperlacrimation, or we are having um, the two things. So when we are doing this Jones dye test 1, okay, so either we are having the positive test where staining is there, or we are having the negative test. So if I am having the positive, that means there is actually the hypersecretion, more secretion is there. And if it is negative, it is not coming, then that means it can be two things. Either we can have the partial obstruction, or it can be pump failure. So in the Jones dye test, actually we are differentiating between this, whether it's a partial obstruction. So when you are doing forceful syringing and then also it is negative, that means it is actually pump failure. But if you are doing the forceful syringing and then it is getting stained, that means it was partial obstruction. So these two can be differentiated by Jones dye test 2. So we are not going into the details of test, but yes, you should know that we have this test and it is used for epiphora or the hyperlacrimation. First वाले का interpretation where we are differentiating between positive and negative, hypersecretion or partial obstruction and pump failure. Now when it is negative and I want to find out the difference between the partial obstruction and the pump failure, then I can do the Jones dye test too. That's it. Then yes, but I will not pass on without telling you the treatment of congenital dacryocystitis, because it is very, very important when I talk about the treatment of congenital dacryocystitis. Number one, if the baby is between 0 to 1 year. Okay, here I will do the lacrimal sac massage. Very, very important hai. And along with this, I can also give the topical antibiotics. We will also give the topical antibiotics, and you should know the name of the massage also. Many times it has been asked directly, Krigler's massage. Then number two, between 1 to 2 years per we can do syringing. So if it is not improving, so I can do syringing now. And then between 2 to 3 years, if it is still not improving, then I can do probing with the Bauman's lacrimal probe we can do. Then between 3 to 4 years, we can do the alternate syringing and probing we can do. And then finally, after 4 years of age, we can do the DCR surgery. Yes, so I have covered many topics here so that you can be covering all the questions of ophthalmology. Like you are getting 20 plus questions of ophthalmology, and same 20 plus topics also I have taken here. Yes. Now coming to the orbit, guys. Very, very important Coca-Cola bottle sign. This is found in the thyroid eye disease. Thyroid eye disease is actually the most common cause of the proptosis. It is the most common cause of proptosis in the adults. Most common cause of proptosis in adults is the thyroid eye disease. And a very, very important thing in the thyroid eye disease is the sparing of the tendons. So this word, if it is written, then you are sure, that you are dealing with a question on thyroid eye disease. Always and always you will have sparing of the tendons, and tendons are origin and insertion. So basically the origin and insertion are not involved in the cases of the thyroid eye disease. पीडीएफ की चिंता मत करो, पीडीएफ में दे दूंगी, बट बेस्ट ये है कि आप लोग खुद से एनोटेट करो. आई विल शेयर बोथ द अनएनोटेटेड पीडीएफ एंड द एनोटेटेड पीडीएफ, एंड आई विल रिक्वेस्ट यू टू एनोटेट इट बाय योरसेल्फ, but anyways I will share the annotated pdf too. Then if I talk about proptosis in children, so if I talk about proptosis in cases of children, if I am talking about, it can be unilateral and it can be bilateral. Unilateral will be due to the orbital cellulitis, and bilateral will be due to the metastasis. This will be due to the metastasis, and metastasis will be coming from AML and the neuroblastoma. AML as well as the neuroblastoma, right? Now, very important is the trauma, especially for you people, because one question will definitely come from trauma, that is for sure. ये देखो, and this particular picture is again a very very frequently asked PYQ, where you will get this kind of picture, teardrop sign. This is called as the teardrop sign, and teardrop sign is found in the blowout fracture, and blowout fracture is most common in the inferior wall or the floor. This particular picture also has been asked so many times. You should know that blowout fracture is found in the blunt trauma, most common in the inferior wall or the floor, that is there. Very very important hai. Then another important thing is this one, whenever they are giving the history of blunt trauma, you can get this kind of ring. This ring is called as the Vossius ring. सरकारी क्वेश्चन क्या होता है? I do not know this term. What do you mean by that? So Vossius ring है. This is on the anterior surface of the lens. Anterior surface of the lens पे you are getting the Vossius ring. Guys, I hope you people are studying along with me and enjoying the most important questions on ophthalmology. Please comment, कोई भी अगर doubt होता है, please keep on telling me, and try to annotate the PDF afterwards by yourself, and for your help, an annotated PDF will also be shared to you. ठीक है? Then if you are getting this kind of picture, right? So this is a intraocular foreign body, and most commonly it is the chips of the iron. Most commonly you are getting this, the chips of iron, and iron is magnetic. Therefore, MRI is contraindicated. So this is also a very important PYQ. Like retinoblastoma, it is just the opposite. Their MRI was the investigation of choice, and CT was contraindicated. Here, MRI is contraindicated, and investigation of choice is the CT scan for the localization of the foreign body. This is also a PYQ question, right? Then some of the important things about the uveitis. So uveitis may we have an important thing called a sympathetic ophthalmitis. Here you should know that it is actually a pan uveitis. It is a pan uveitis condition, and it is basically occurring due to the trauma, and the type of trauma is the penetrating type of trauma. These are the two important PYQs which have been asked recently, 2020 and 2022, about the sympathetic ophthalmitis. So whenever there is a trauma of the ciliary body, we can have this sympathetic ophthalmitis. Not only the trauma eye, but the other eye is also getting affected, and it is affecting, like from unilateral, it is going to the bilateral other side in about 4 to 8 weeks. It is going. So ट्रीटमेंट के लिए वी आर गिविंग द स्टीरॉइड्स, लेकिन इफ दे आर नॉट वर्किंग एंड द inflammation is not subsiding, then we can do the e nucleation. then we can do the enucleation. Initially, we can give the steroids. If it is not getting controlled, then we can go for enucleation. Then the squint. Now, yes, squint is not a topic from where so many questions are asked, but yes, we cannot totally miss it, and you can get a question from squint. So, one important thing in the squint is your third nerve palsy. Whenever we have third nerve palsy, the eye, first of all, will be down and out. The eye will be the down and out. It has gone down due to superior oblique, out due to the lateral rectus because SO4 hai and LR6 hai. So these two muscles are working and therefore the eye has deviated that side. We will also have the LPS palsy. Due to the LPS palsy, we will have ptosis. So third nerve palsy mein ptosis is also there, down and out is there. Along with this, pupillary reflexes. If I am talking about the pupillary reflexes, these are absent because third nerve is the efferent nerve. So pupillary reflexes are not present here. But there is something called as the pupillary sparing. There is something called as pupillary sparing third nerve palsy. Pupillary sparing third nerve palsy, it is found in the diabetes and hypertension. You should remember this. So in cases of the third nerve palsy which is occurring due to diabetes, which is occurring due to hypertension, you will get the presence of the reflexes, right? Another test is the Hirschberg test. This is a test which is a corneal reflex test to find out the amount of the squint. So you should again know the name of the test and the work of this test in order to find out what is the amount of squint roughly from the corneal reflex. Therefore, it is called as the Hirschberg corneal reflex test. Okay, so you should know what is this test and why it is used for. Then this is the another test that we are using in the squint. This is called as the Maddox rod test. So you should know how to identify the Maddox rod. And this is another test which is used for the squint. One test that we are using is a cover uncover test. Like this, occluder we are using Maddox rod test, Hirschberg corneal reflex test. One is your cover uncover test that we can use. Then Maddox rod test is there, Hirschberg corneal reflex test is there, and last but not the least is the Park's three-step test. Park three-step test is found used to find out in cases of the vertical squint. Whenever we have the vertical squint, so you have to find out which muscle palsy has occurred. So you don't need to know how to do this test, but you need to know that we are doing it to find out which muscle is paralyzed in cases of the vertical squint. Yes. So this is called as the Park's three-step test. So with this, we have come up to the end of this session, but this is not the end, and end will be on the day when we will be seeing you not only pass, but having a very good score, decent score, where you are having a feeling that yes, I did my best and I'm happy with my score, guys. Wish you so much of good luck, so much of good health, as well as so much of positivity, as well as self belief. Nothing is possible without the self belief and motivation. So, we are always there to help you. I am always there for your ophthalmology doubts. So, after the session, give me some time. I'll be sharing the annotated PDF also on the Telegram group. Do write to me if there is any doubt about it. Do practice this PDF so many times. It has 25 images which are most important. All the PYQs I have incorporated in this, all the PYTs have been incorporated with it. So if you are sure about these topics as a whole that I have shared, you are prepared for ophthalmology, you are ready for ophthalmology, revise it several times and let me know what else I can do for making your ophthalmology the best. So thank you so much guys, good luck and happy ophthalmology. Goodbye. Uh, Yeah, somebody has asked me chemical injury management. Okay, yes. When we have chemical injury, right? Chemical injury may see we can have acid injury also as well as alkalis injury. Acid injuries as well as alkali injuries, where alkalis are more severe. These are more severe, but the treatment is same for both. Number one, you have to do the intensive irrigation. And one more disclaimer I would like to tell you guys, whenever there is a emergency like chemical injuries, you will not do history and examination at that time. No history, no examination. Straight away you will start with the treatment. First step is always intensive irrigation. Number two, may we have to do the double eversion of the upper eyelid, because we have to remove the deeply embedded particles. Number three, per we will do the removal of the dead tissue, debridement, removal of the dead tissue we have to do. And number four, pe we will give the drugs. Now, drugs may I will give the steroids because of a lot of congestion. I will give the tetracycline or the tetracycline group of drugs, as well as we will give the citrates. These are the three drugs that we are going to give, because they are anti-proteolytic, anti-collagenollytic, anti-neutrophilic. So they are preventing the perforation and acting as an antidote. This is the treatment for the chemical injuries. What's important in the topic of uveitis and conjunctivitis? That I have already covered uveitis and conjunctivitis, sympathetic ophthalmitis. We have covered acute red eye, acute anterior uveitis. We have done conjunctivitis. May we have discussed about vernal keratoconjunctivitis, that we have done. Now if you want to do more, you are most welcome. So from the in the class we have done so many types of conjunctivitis hai. We have done mucopurulent, purulent, membranous conjunctivitis, hemorrhagic conjunctivitis, angular conjunctivitis, ophthalmia neonatorum. But here I had to discuss the 25 most important topics, so that much I have covered here. Then any other question, guys? So I think this is all for today. Thank you so much, guys. Take care. Goodbye. Happy ophthalmology.